Low testosterone is a problem that we see commonly as urologists in the office. We see it typically in the aging population. This is something that happens naturally with aging as testosterone goes down by 2 to 3% per year starting around age 30 or 40. It's a conglomeration of symptoms including fatigue, loss of muscle, decreased desire for sex, decreased erectile function, as well as difficulty with losing fat around the central area of the body. Risk factors for low testosterone include simply aging, chromosomal abnormalities, childhood illnesses such as mumps, orchitis, chemotherapy, trauma, undescended testicles, and obesity. The diagnosis of low T is a simple one. Very simple lab tests can be drawn to see where the levels are, but most importantly, you want to key on where their symptoms exist. There are several treatment options for low testosterone. The first question I ask a gentleman is whether or not they are done having children. If they're done having children, then you can use exogenous testosterone. If they're not done having children, then you want to use something that will make them make more of their own testosterone. So if a gentleman needs to have more of his own testosterone made, I'll use HCG, or human chorionic gonadotropin. This is an injection that the patient gives to themselves every other day at home. The other option would be Clomid, which often is used to stimulate females' ovulatory cycles, but it can also be used in the male to stimulate production of LH and FSH and therefore more sperm and more testosterone. This is simple, 25 milligrams a day, half of a pill, and it does the trick. The exogenous testosterones will subsequently shut down the patient's own testicular function, therefore dramatically reducing their sperm production, as well as their own testosterone production. However, there are several options. There are topical gels and creams, which are put on by the patient once a day. There are patches, which can be changed on the skin by the patient once a day. Injections of testosterone, which I often will teach my patients how to do, and they administer their own medication at home about once every 7 to 10 days with needle and syringe. The last option would be pellets, which are put under the fatty part of the skin in the buttock region. That's done in the office about once every 3.5 to 4 months. Side effects of low testosterone treatment typically are not very significant. The things that I ask my male patients to watch for is loss of hair and acne. Again, those can be reversed. In addition, we want to watch for breast swelling and tenderness, and also I want to watch for the effect of testosterone. If a patient comes in and they're having loss of hair or acne, again, these can be reversed with the use of medications such as finasteride or Avodart, as well as the use of spironolactone. If they're having breast swelling or tenderness and or non-response to a very good testosterone level, what I'll do is I'll check their estrogen levels. If the patient's estrogen levels are well above 100 and we're seeing some of these breast symptoms or lack of effect symptoms, I'll use a drug called Arimidex. This is an aromatase inhibitor, and what this does is it prevents the conversion of testosterone to estrogen at the level of the fat cell. Often patients do get very focused on certain levels in labs, such as estrogens. Most of my patients do not take Arimidex, probably only about 10% do, as I don't feel that it's necessary to keep the estrogens very low in every single patient, as they don't have effects of it as often as one would think.